Welcome to the Honest EP podcast. We're the podcast for health professionals and the wider community. Look to explore diverse ideas in health, ask some hard questions, and have some honest conversations. My name is Archie. I'm an EP based on Sydney's Northern Beaches, and joining me as always is allied health business owner Andrew. Andrew, how are you today?
That was a bit more subdued than the last few times.
When there's a bit of a boom behind.
Oh, right. So we're setting a different tone now, are we?
Well,
smoothing
so
in.
You would have obviously just heard the intro music, which we've only had for one episode.
Wow.
And when we record the last episode, we didn't have the intro music yet recorded. So, and I started the last one very, very hot, which didn't fade particularly well with the intro. So now I feel like I've got kind of a smooth beat behind it. I've got to go a little more subdued. I don't know. We'll mess around with it.
Very good.
I'm just excited to have some music.
Exactly right.
Which, for anyone that cares, was made by my brother, Jas, who is a producer and DJ, does a lot of techno stuff with a group called Undisclosed, if anyone gives a shit. And if you like techno, go follow Undisclosed on Instagram.
Fantastic.
There you go. But
How good.
thank you, Jas Manning, for that one. We got a beer. We should probably open a beer.
We should.
All right.
Again, I've had to scrape the bottom of the barrel and go up to our little local bottle-o just up the road, and they do not have the most extensive selection, but we do have this Stone and Wood Hinterland Hazy Pale Ale.
Yeah.
First impressions?
It's weird when you open a Stone and Wood. Everyone kind of knows what to expect when you open the Stone and Wood, because we've all had the Pacific Ale in the orange kind of logo, and this does not taste like that.
It does not taste like orange.
No.
It tastes a bit like green.
Yeah, it's the Hazy Pale's got an interesting an interesting taste to it, and I don't think it's one of my favorite tastes. Like, we like pale ales, and we like IPAs at the moment as well.
But the hazy,
this weird middle ground doesn't seem to work super well for us. Or me.
No.
You?
No. I definitely, if I had to pick any Stone and Wood, I would not pick this one. I would pick the other one.
The normal one, the Pacific Ale. Yeah. I'm not even aware they did other beers, and there's probably a reason we haven't seen this one anywhere, because it's average.
Sorry, Stone and Wood.
Sorry. I think we might take a break from hazy pale ales from here, or maybe it's because they're using Victorian secret hops, which it says here.
Secret hops.
So that's the problem. It's got Victorian hops in it. They should have stuck with Byron Bay hops. That would have been absolutely fine.
Excellent.
Anyway, we've got a topic to talk about. If you work in New South Wales, you probably would have received an email last Wednesday on the 6th of March.
6th of March.
From SIRA, who for those non-New South Welsh people, is our Workcover and CTP claims. So VicSafe is the equivalent in Victoria. I don't know what it is in Queensland Safe. Queensland Work.
Something like that.
And WA something, and yeah. Anyway, it's
Workcover.
It's the people who do the Workcover and the CTP claims, the insurance body, regulatory authority for that. They released an email. They sent out an email, and the email said, it's time to implement SIRA's model of care for the management of low back pain summary. And a message from SIRA. This has been coming for a while. We were getting stuff last year saying, hey, recommendations on the way to treat low back pain in Workcover setting is changing. We know APA sent out a thing to their members saying, hey, we don't want change for reasons, so we're going to fight against it. And we're like, okay, all right. I don't know how much people cared too much about that one, but they seem to have gone ahead anyway. So clearly not too much. And basically,
not that much.
We'd like to pick through it and see what the most interesting parts of it are, and talk about what we like, what we don't like, and probably what its implications are as healthcare practitioners working within the Workcover setting. So to start, it gives you a 14-page PDF, and they work through it and talks about a bunch of different pathways for different types of back pain. Overall, Andrew, from reading it today,
Yep.
overall, what are your thoughts?
My thoughts are that, well, I was actually just double checking because you mentioned that the APA were jumping up and down before this got released, and I was looking at the expert advisory group that was put together.
Yeah.
APA was not on that list,
No.
which is a bit awkward.
But to be fair, none of the other professional associations are either.
No.
Who all work with low back pain. I didn't recognize a lot of the groups, if I'm honest. A lot of specialist and surgeon and orthopedic institutes and this kind of thing are in there. And like general practitioners, this kind of stuff. So they seem to have stayed away from allied health institutes or allied health bodies, probably for a reason, because they're probably feeling that like we don't want people to try and put their spin on it that favors a particular profession, because they've stayed very neutral in terms of, well, as they should, because they're a regulatory body. They've stayed very neutral in terms of talking about the practitioners or the allied health practitioners that can or should be part of this pathway. So looking at it, overall thoughts of have they hit the right areas?
So for clarity and for those people that have not seen this document, essentially they're laying out 3 pathways, right? Pathway number 1 is for non-specific low back pain. Pathway 2 is for acute low back pain with progressive neurological loss. And part C is acute back pain with leg pain. I don't know. My first impression in reading it is that there are some very nice diagrams and very nice kind of flow charts going through here. And, you and I were actually chatting beforehand in the 5 minutes of preparation we did for this podcast. And you made a great point there about that for some people, some professionals, irrespective of their profession, this might be somewhat new to them. And I think one of the good things about this document or whatever you want to call it, model of care, is that it does try to bring like some minimum competencies or minimum
standards of
minimum
care
standards.
Yeah.
Because again, like irrespective of profession, Workcover is certainly one of those schemes where it's easy to not question yourself as much. It's
Exactly.
easy to just do what the patient thinks is best for them. And sometimes that can deviate a little bit from what is current evidence-based treatment for low back pain. And so I think a good thing about this is that it does provide, some practitioners who have been practicing a certain way for a particular period of time, a bit of a reference point about what sort of patient groups would qualify for a more, I suppose, hands-on approach, and what other conditions we might be able to more lean into reassuring them and focusing on movement, as opposed to that direct care. So I think that's probably a good thing.
Yeah, absolutely. Yeah. Minimum standards of care, basically aiming to have all people involved in the care follow a similar narrative and have a similar patient education and risk stratification system to each other, so that you take away less of the, well, my blah told me this, but you're telling me this, and that's different to what this other person told me. So who do I trust? Who should I actually be listening to? And at the same time, I'm being funded to go see all three of you at the same time. So that's like, well, it's shit for us because we're trying to do one thing with you while another practitioner is trying to do something else with you and tell you the opposite. Makes it really, really complicated. And in the meantime, the GP is also saying something completely different. And then they've been referred by their insurer or rehab consultant to go see a specialist as well, because the specialist or the rehab consultant is annoyed that it's taking so long to get better. So like, fuck it, we're going to a specialist. And then a specialist says, you need an injection or you need to have this surgery, which means that every other therapy stops while that happens. And then now we're all taking 2 months, break. And then we've got to start from fucking scratch again. And it just goes around and round and round in a circle. Obviously, these are the more intense cases. So, which, you're right, happen more often in Workcover than they do in a private setting. Because if someone doesn't like what they're hearing from a practitioner they're paying out of their own pocket, or they don't feel like they're progressing at the rate they should be progressing, they stop coming and they go somewhere else. So it's less common to have this kind of, or need this kind of document, I feel like, in a private setting, because people ideally gravitate to good practitioners and pay the people they want to see instead of seeing the people they've been told to see and going, well, it's not costing me anything, so I'll just continue to come for 6 months even though not much is changing. And I'm getting paid a portion of my salary while I'm not working as well. So less complicated in a private setting. This is more complicated in terms of the funding. Therefore, this is probably more necessary. And hopefully it does something. So in terms of like they go through the key principles on the third page. And I quite like this because I think this is where people should start. And it simplifies everything. But it kind of talks through like, hey, look, everyone should be doing this when they see someone with low back pain, no matter what. And it's like, okay, most of this stuff I agree with. First one, assessment, history, and examination. Cool, great. Rule out red flags, determine pathway of care for an individual patient. Cool. We can't really fault that or do anything wrong. That's kind of what happens with everyone. A formal history. I don't know why it has to be formal, as opposed to an
informal history. Yeah, very good.
Useful sentences, no dot points, please, when you describe your history to me. Second one, risk stratification. This is where it gets a little interesting. So use tools, risk stratification tools, such as the start back with 2 capital T's in it. And Arebro questionnaires to stratify patients according to risk level. We've looked at the 2 things. So full disclosure, I use the Arebro for a lot of clients, especially ones in the Workcover setting, because it gives me like a subjective questionnaire measure, but it squirts out a number for me, which is nice to put in the AHRR. And it also brings up some interesting questions and topics that can be useful to inquire further with the client. Things like, do you think, on a scale of 1 to 10, how likely do you think you are to be back at work in 3 months' time? Or how likely do you feel like it is for this pain to become persistent long term? Things like that, which is actually useful to know on a scale of 1 to 10. The start back, I don't know.
as opposed to the good quality Arebro.
I haven't used this. This is the first time I've heard about the start back screening tool. But I opened it up today. I was like, I don't really know what I'm finding out from this on this tiny scale. That's a 1 to 9 of a disagree or agree. And disagree is worth 0 and agree is worth 1. So you end up with a score from 0 to 9 out of this one here. And the questions are just a little, probably, they require more than a 0 to 1, I would say.
Can you give us an example?
Sure. Worrying thoughts have been going through my mind a lot of the time. Agree or disagree?
Worrying thoughts.
Worrying thoughts.
A lot of the time.
Okay. Yes. So that's a great from you. Great. Thank you. 1.
But that's not related to my back.
No.
Oh, sorry. Okay.
I've got what I need.
You have labelled me.
The next question. I feel that my back pain is terrible and it's never going to get any better. Agree or disagree?
Terrible. No, it's not terrible. It's horrifying. Where does that doesn't fit on your scale? Disagree. Okay.
0.
Damn it. It is mildly terrible.
This is my favorite one. In general, I have not enjoyed all the things I used to enjoy. Agree or disagree?
I could say that about anything unrelated to back pain. All of the things.
How can you ask, in general, I have not enjoyed all the things I used to enjoy? It doesn't say physical activities. It doesn't say work. It doesn't say hobbies. It doesn't say personal relationship or life. It doesn't say food.
In general.
Yeah, you're right. I don't like chippies anymore.
Therefore, I agree. That's got nothing to do with my back pain. I just don't like them anymore.
Yeah. What if they're like, well, I used to enjoy wine, and now I enjoy wine even more. So you disagree then, because that's a thing, and this is in general, and you not enjoy it at all. So that gives you a 1 score there then. And the last one, right after these wonderful questions, is overall, how bothersome has your back pain been in the last 2 weeks? Okay, it's a fine question. And it gives you a scale here, like a 5-point Likert scale, which is very nice. So not at all, slightly, moderately, very much, or extremely. It's like, okay, great. The problem is it's still scored on a 0 to 1 scale of not at all, slightly, and moderately, all being worth 0, and then very much and extremely being worth 1. So you could say, how bothersome has it been? And you could say, not at all. And you could say, well, moderately bothersome. That's also a 0. So unless you say very much or extremely, it's not worth any points. So then this gives you a score. And then it spurts you into a 3 or less, low risk, 4 or more, with a sub-score for the last couple questions, which are more like the psychosocial ones, being 3 or less, medium risk, and then 4 or more, high risk. It's like, great. But like, why the fuck do we need a questionnaire to tell us this in the first?
You're probably just better to ask the person.
Just ask the
on a scale
person.
of like 1 to 5. How risky do you think your back pain is?
But also, can you imagine how shit of a question it would be if you were talking to someone about like how their back pain's been, and I go, Andrew, in general,
can you do?
Have you not enjoyed any of the things you used to enjoy? Yes or no?
What do you mean? Can you give an example? No, I can't.
Can you just agree or disagree with this statement? That's all. Like, what are we doing here?
This is silly.
So I don't know how that one snuck into the everyone should be using this as a principle. Probably not. A rebro, very good. Gives you a nice score. Generally gives you some good questions to inquire further into. If you haven't looked at your Erebro, look at the Erebro. It links it to you in this document here. Principle number 3. Pardon me. Only image those with suspected serious pathology.
Makes sense.
Makes sense. That's good. Let's not fearmonger and go, fuck, get an MRI.
Which is a pain in the neck when it comes to Workcover specifically. But like other things also more generally, because if something comes up in there, then oh geez, like not only is it like, well, that's the reason that I'm in pain.
Yeah.
But it's also that, well, you're my employer and you caused that. So it's your fault, the fact that I've got this thing, and so you need to fix it.
And I'm not fixed until the bulge, or God forbid, it says something extremely common like degeneration, and you go to your employer, it's like, you caused my degeneration. You're going to pay for this for the rest of your life.
Oh.
Because you're not fixing degeneration. It's not going to regenerate as such in terms of like what the MRI finds. So
very, yes. I would concur that is a good thing. Like, only when it presents as serious and red flag should we look for pathology.
Yes. I feel like that makes a lot of sense. There's plenty of resources out there that will tell you that and follow that. And that's kind of going that way with a lot of musculoskeletal stuff as well. Even like osteoarthritis and these kind of things. Like, you don't need a scan to diagnose OA anymore. You can do it based off the symptoms. And the image findings, like the joint space and evidence of the cartilage degeneration, is not correlated to the level of pain people are feeling anyway. So for people to go, well, you have severe osteoarthritis, but you're not feeling much. It's like, great, well, you ain't going to make them feel worse.
Well, I feel it now. Yeah, thanks
like,
very much.
This is a very severe, mild discomfort you have in the mornings. It's like, oh, no. I thought it was just a bit of morning stiffness.
Yeah.
It's like, no, it's severe.
It's severe.
You've got no joint space left. So, yes, let's screen when we need to.
And then we educate, apparently.
Then we educate.
We principle for patient education.
Yes. Each person will receive one-on-one education supporting self-management. This will include advice to keep moving and try to do normal activities as much as they can. Yeah.
Lovely.
Yeah, very good. What's interesting is when you go and actually look at like the key messages to the patient, which are further down, I also agree with a lot of what they're saying because there is good evidence to suggest that providing advice to keep moving and try to do normal activities as much as possible, including staying at work, and some pain may persist, but returning to activities despite pain will improve the speed of recovery. On the most part, very good advice. Good education. So we like that. And then it even goes into some language stuff, which I also like. I don't understand the dot point of apply the biopsychosocial approach. It's like, well, it's not really like apply the approach. It's more just like understand how pain neuroscience works is probably a better dot point to say there, rather than like apply approach. Saying having back pain does not mean your back is damaged. Most back pain is linked to minor strains that can be very painful. I don't quite understand how that's helpful. That's okay. Encourage normal activity and movement. Yay. You get back, your back gets stronger with movement. Yeah, it's all right. Motion's lotion. That's cool. That's good. I actually don't mind this one. The movement may be painful at first, like an ankle sprain, but they will get better as you get more active. Don't mind that one at all. Yeah. So they have some good things like that. And then they have some language to avoid, which I also agree with this in the most sense. It's like avoiding language that promotes beliefs around structural damage, like disc bulges and slipped discs damaged and wear and tear. It's like, good. And it goes, suggestions that pain indicates damage by not using phrases such as let pain guide you and stop if you feel any pain. Those ones I don't agree with entirely, because there are some situations where if people are in a very acute flare-up or they're very, very sensitized, saying, nah, just keep working through it, you'll be right, often doesn't sit super well with the human. So you kind of got to read the human and their situation in front of you. Also, if you've got a person who likes to constantly work through pain and as a result is not actually allowing their body any time to recover, well, then it's not always a great idea to go, keep working through the pain, because that's what they've been doing and it's not working. So generally those people, you've got to bring them back to like a a level of like, hey, let's give your body some time to recover and heal a little bit, or just desensitize a bit, stop being so inflammatory and all the activity you're doing and pissing things off, and then we can build up again. So I think there's a little more nuance to the education they're doing there, but in the general sense, not too bad. There's definitely a lot of this language that is being used incorrectly in the Workcover setting, where you have people come to you and they've got all of these crazy beliefs about all of these things they've been told from multiple people, and you go, fuck, it's going to be more complicated than it had to be if someone started with this stuff. So if someone does start with this stuff early on, make everyone's lives a lot easier, that's for sure.
And I think that's a really good point, because this document in itself is not just for allied health professionals, right? Like, this is a good resource or reference point for generally that first port of call for somebody who's had a work-related injury, which is their GP generally. And while in the the relatively short consultation time that a GP has with someone, they might start be able to reinforce some of these key principles, which I think is great. And it's sort of our job then to sort of carry on, as opposed to a GP saying, oh, stop what you're doing. Here's some medication. Go over here. Like, they'll do manual therapy on you. For before people can start to generate those beliefs, to have a primary healthcare person sort of, no, that's okay. Like, this is okay. We'll get through it.
Yeah.
And we'll get you the support that you need.
Yeah. Have you had, well, actually, so many people must have had this, that you've been doing something with someone and then they've gone to see their GP and their GP says, what, you've got back pain? What are you doing with the EP? It's like, deadlifts. It's like, stop deadlifting.
Deadlifting is bad for your back.
You're going to hurt yourself. And then they come back to you and then you got to deal with that now.
Yes, it's lovely. Presumably that GP... Oh, I'm generalising now. Presumably that GP has never deadlifted. So be careful who you take your advice from.
Yes.
But yeah, no, and I think it speaks to that level of trust or level of authority that people have in, for people in positions of, respect or authority in the community. That if a GP says, like, do this, it's like, oh, I've got to do that then. It just carries so much weight and takes so much more time for us to unpack that and sort of start to rewire that belief that may or may not have been said with intention originally.
Exactly. Yeah. Like, maybe they were just saying, like, when did you hurt your back? And they go, oh, well, I was doing some deadlifts at the gym. It's like, okay, well, stop doing that for now. And then people take that to heart. And it's like, never deadlift. That's what my GP told me. Or I'll always hurt my back. And you can go, fuck. Doesn't take much with language, does it? Language is so powerful, especially in a pain setting. That, like, and I don't want people to be, like, afraid of talking, but making sure you're not, like, using too many no-cebic phrases and being aware of, like, what you say to people, they will hold on to and can influence their future experiences a lot. Because a lot of the time people come in, and if they've been through the ringer, they have been dealing with an issue for more than 6, 9, 12 months. They come in, they've normally seen a bunch of people, and it's always a good idea to find out, okay, who else have you seen? And what did they talk about with you? How did they explain your pain to you? Or how did they explain what your injury is to you? And then, great. So from that, what's your understanding of what your injury is and how it's going to get better? And before you start to, like, load more advice and education on top of people, often you need to, like, peel back all of that stuff first. Because if you're just adding more stuff into this already overloaded sandwich, like, how are they actually going to taste the extra stuff that you're putting in the sandwich? It's just going to taste like shit. Yeah. too many flavors, too many sauces in the burger. There's already.
I'm hungry now. I want a sandwich.
I want a burger. Oh dear.
Can you so further down this document? There's these lovely kind of flow charts.
Oh jeez.
Which are great. And I think the topic that I want to talk about is that in this document or in these flowcharts, there are specific times for reassessment, is what they call it. You reassess at 2 weeks, at 6 weeks, and at 12 weeks. And you're doing these are rebro or these. Well, you're not doing the start one. You're doing the good one. But I read this and the perception that I get is, well, what happens in between?
Yeah, they haven't really given a whole lot of guidance on what to do, rather than just like, this is when you reassess, this is what you do to reassess, this is what you educate on, and help them do self-management. Maybe it was too much information to try and put into a document about like what appropriate care for lower back pain is, or maybe like the general advice they gave leaves it up to the practitioner to go, great, this is my general guideline. Now I've just got to work to patient preferences. So you can like, they don't spell that out necessarily, but that's what I take from it. That it's like, hey, you should review progress at 2, 6, 12 weeks, which is very specific. And it literally has a principle that's like, have predetermined times for review. It's like, okay, I guess that's just a very Workcover thing, that like, this is when you should be checking in with the insurer and the rehab consultant and providing reports and yada, yada, that kind of stuff. And like, this is when your SMART goals should, this is the timely part of the SMART goals in the 2, 6 and 12 weeks. It's like, all right, okay, that's what they want. But I don't know. Maybe I read into that just my own bias is like, great, so I'm actually free to do quite a lot of things, and it depends on the person in front of me. And if that person likes swimming and they're not swimming at the moment, then great. Let's grade you back to swimming for your back pain. But if they hate the water and they can't swim, I don't need to do swimming with them. Or they hate doing weights. Maybe I don't have to just do a weights-based rehab program. So there's quite a few different ways you can look at it there. How do you look at those time frames, and what do you read from those?
Yeah, I sort of get the same feeling that these are, I presume that they've been chosen for a specific reason, like assessment 2 weeks after, 6 weeks after, 12 weeks after. What I was kind of reading through in this document was what happens if there was no improvement at either like any of those points. Which was interesting because then it comes back to like how they stratified or how you stratified risk. So if there's no improvement after 2 weeks and somebody is low risk, so no improvement after 2 weeks, low risk, further education, review analgesia, encourage normal activity, and support self-management.
So okay. I don't know if you heard me 2 weeks ago, but you're not listening. Back pain is rarely serious pathology, and it's not tied to structural damage. Do you get it?
But it still hurts.
Now go away for another 4 weeks and come back at week 6.
So low risk.
Idiot. Re-educate them again.
Jeez.
Let me get my.
Do I need to draw it for you?
Do I need to show you the fucking PDF with all the dot points on it?
Look at my flowchart.
Lotion is lotion. All right.
Can I have some lotion? So low risk, you just educate and encourage activity. Medium risk, as per low risk, plus more physical therapy. And high risk is as per medium risk, plus continue targeted management of obstacles to recovery identified in screening tool.
All right. Let me identify these obstacles.
Oh, hang on. That's my general well-being, isn't it?
So, are you not enjoying those things you used to enjoy yet?
In general.
Why not?
You should enjoy them again.
Because it hurts. Well, that's an obstacle we're going to avoid. That means obstacle doesn't exist anymore. Because, don't worry about the pain, mate.
Because motion is lotion.
And it doesn't matter. It's not tied to structural damage. So you're good.
Don't worry about it.
Just chill out.
Just chill out.
Don't let pain guide you. Don't stop if you feel any pain. Just do the things you used to enjoy. Idiot.
God. So if I'm a practitioner, I read this and my client hasn't improved. I'm like, this is starting to not help me now.
The flow chart is a little prescriptive, a little simplified.
It's simplified, and there are some nice words in here, right? They're using all the right words, but there is a lot of nuance in here.
Yeah, you wouldn't want to read this and not already have a good idea of what is talked about. If this was all new to you, you'd be like, "Fuck, I don't think I can help." I don't know how many people you'd help.
Well, I think what would happen is you'd get to the 12-week reassessment. Things have not changed. And then it's like, well, fuck. I can't help you. Because then it says, well, if there's no improvement, you consider referral to a multidisciplinary pain management program. It's like, well, that's... we've gone from 0 to 100 pretty quickly.
Or how about Principle 10 that says... if patient has no improvement or worsening symptoms, consider a review by a musculoskeletal specialist at 6 weeks.
Is that enough time?
It's so individual. And it depends what else this person is doing. So maybe if you do everything correctly, like you're supposed to, maybe 6 weeks is enough time, assuming that the person listens to you. And if this is an acute back pain diagnosis, or acute non-specific back pain diagnosis, there's no fractured vertebrae or anything, that's probably enough time, because just with general healing times and the way most musculoskeletal conditions work that are acute, it's hey, you're probably going to feel better in 8 to 12 weeks, regardless of what we do, assuming you just keep moving and not avoiding using things and doing all these unhelpful behaviors and putting obstacles in the way and that kind of stuff. So, yeah, I'd like to think so. Actually, to be fair, yes, I do agree with this. If I had noticed no change in someone's condition after 6 weeks of seeing them, which in Workcover, that could be anywhere from twice a week to once a week to a fortnightly to once every 3 weeks in that period. If I hadn't seen any change in 6 weeks, I'd probably be a little concerned that I'm either doing a shit job or there's something...
sinister.
There's something more sinister going on.
Yep.
So actually, I agree with that.
Nice.
I'm going to say that 6 weeks, you should have noticed change. If you're not noticing change in 6 weeks...
Second opinion.
What I find with a lot of musculoskeletal specialists, although when you read a bit further down, it tells you what a musculoskeletal specialist is, and that makes you feel a little bit better. So if you go down to the glossary of terms... They describe what a musculoskeletal specialist is. And it says specialist physiotherapist, rheumatologist, sport and exercise physician, spine surgeon, or pain and rehabilitation physician. Cognitive CBT trained physiotherapist and or clinical psychologist may also be considered for these medium or high risk. So it actually does give you some information about what that is. I definitely lean towards staying within the allied health system before going to a specialist, especially in a Workcover setting. Just because and this becomes very individual.
Do it.
But like my experience with when people see a specialist in a Workcover setting, the specialist basically has a blank check. And it's like, cool. So Workcover sent you, have they? Well, I basically got a green light to do whatever I want here. And this sounds horrible. This sounds horrible. I completely understand that this sounds horrible. But they're going to do something. They're going to do something.
Particularly if they've got some findings, some pathology that says all of those terrible words.
Yeah. And very rarely would it be less than, let's inject some steroids into you. So a cortisone injection. All right, let's start there. And we know that they have iffy results. Sometimes they're great. Sometimes they do nothing. Sometimes they do a medium amount, but there's no rhyme or reason to it as far as we can see in the research. So other than they lead to, or they are correlated with an increased risk of further pathology and arthritis down the track. So that's what we do know. So generally speaking, I wouldn't love it. But a lot of clients get them, and sometimes they help. So if you're really getting nowhere, maybe that is the best thing. At worst case, they go, well, let's go in there and like do a denervation or fucking a disectomy. Cut off this spurting splatter disc in your spine. Because that's clearly very dangerous.
Yeah.
Sometimes it is. But yeah, I'd rather go to a specialist physiotherapist or a sport and exercise physician, whatever a sport and exercise physician is.
There are a couple near us, and the good thing is that they generally do. There's generally a bit of upskilling that's happened in like physiology and exercise rehab, and so this is again huge generalization. But the ones that tend to be that I've had patients go and see have had the message like, no, keep doing rehab, like keep doing exercise, because even if we do cut you open at some point in the future, being fit, being strong is going to help in the long term.
And the authority from them helps. In terms of, great, remove those obstacles, do the things. So that's always a good place to go. Yeah, okay.
So imagine you're somebody with 0 to 1 year reading this document. Does it change anything for you? Like, does it change, like if you were mentoring new grads around like this and how it fits in with a Workcover, or how it fits in with a patient journey, like would you be changing the way that you plan your treatment for people?
I think it depends on your setting and what your current experience is. I don't think it would change the way that our 0 to 1 year practitioners do things that much, because it's kind of my job to make sure that they know the general gist of this stuff anyway. If someone comes in with back pain, it's like, de-threaten things, move, rule out flaggy things, and do what's important to them, get them back to meaningful movements, go through some educational points that are relevant to them, don't over-educate, build rapport, build trust, all the normal stuff.
Hang on. Don't over-educate.
Don't over-educate. Don't add shit to the sandwich.
What is that? Oh, the sauces.
Yeah, don't add all the sauces to the sandwich. If you've got a hot dog and you've already got ketchup, barbecue sauce, and mustard in there, what benefit is there to also adding a chipotle or a mayo? Or does that can you taste it, or does it just taste like a really weird ketchup, mustard, barbecue sauce mixture at that point? Can you clearly define the taste of the mayo when you're already having it on a sausage sizzle with all those other sauces?
Define the mayo.
Yeah. It's like, what flavor mayo was that? Was that a garlic mayo? Was that a sriracha mayo? What kind of mayo was that you had on top of the mustard, barbecue sauce, and ketchup on your sausage sizzle with onion? It's like, no, I can't. It's too confusing. Guess what? That's what overeducating is. If someone's come in and you ask them, it's like, so what do you think's going on with their back? And they go, well, my core's weak, but my pelvis is out, my posture's bad, and I deadlift wrong, and work's fucking me over. They're working me too hard. My seat in the bus that I drive at work is too hard. They put me in this position too much, so that's messing me up as well. My bed's too hard, and I've got all these bulges, and they're fucking me over. And one's about to slip out. One is literally going to poke one of my passengers in the eye if I bend forward too far. So, and you go, mate, movement's good. Don't worry about it. Just motion is lotion. And don't listen to the pain. It's like, it's not structural damage. And you add that on top of the other shit they just told you, that's not cutting through the fucking skull. That's not even getting past the scalp into their brain, and they're not taking a word of that on board unless you are like the biggest dog in the world and your Lamborghini is parked right at the front of your luxury Bondi home that they've pulled up to for their specialist appointment with you, and you're in a lab coat with a stethoscope and you've got a wise grizzled beard and you're floating with a halo above your head. Then maybe that education gets through to them. But if you don't address any of that other shit first, if you're a regular Joe like the rest of us who aren't Jesus, then that aren't Lorimer Mosley, I don't know, name someone, then it's probably not going to work. You're probably going to have to break down some of these beliefs first and do what Principle 5 tells you to do, which is the cognitive behavioral approach. Which,
Lovely.
like, it does not give you enough information here, but this document is not trying to tell you how to do your job exactly. It's given you the principles, and then it's up to the people to go and learn the principles in more depth. But it says, principles of CBT are used to ensure the patient is supported to understand the relationship between beliefs and behaviors and to develop a goal-oriented plan of care. So if they have all of these beliefs, imagine what behaviors they're going to be doing. And you saying, just move, it's fine, isn't going to do shit. If they think a disc is about to slip out the back and poke someone in the eye, they're not going to just bend over and move comfortably.
Can I ask you a question?
Yeah, you can.
Thank you. Let's say somebody believes that manual therapy will help them. Does this document, does this prevent, in your mind, does this prevent that from happening? And I'm trying to make that like a fairly broad, because it can be, manual therapy can be applied in different ways. But like, if a patient's belief is that this will help me, does that just get put to the side? And it's like, well, have you checked out this flowchart? Because apparently, like, all we need to do is fucking lotion you and everything will be fine.
See, that's where I don't love some of this wording. Principle 6, active physical therapy encouraged. Great. Awesome. I'm all for that, seeing that I am an active physical therapist. Physical, I mean that in general term. No, I'm not a American physio. just like I use a physical therapy. Physical therapies will be primarily a hands-off approach. Primarily a hands-off approach. So I don't love that terminology.
They didn't say exclusively.
They didn't say exclusively. But I don't think it helps necessarily to say that, especially when someone thinks or has a belief that manual therapy or some hands-on therapy is going to help. I'd do it. If I was a person who had hands-on modalities in my tool belt, like a osteo, a chiro, or a physio, and someone said, I know that manual therapy is really going to help me in the short term, I'm doing it. I'm doing it. And while I'm doing it, I'm talking to about all the other important things that they need to do as soon as they leave. Because if they're going to feel good for half hour while they're with me, but the other 23 and a half hours a day, they ain't doing shit. And then they're not doing anything for the next 72 hours before I see them later in the week, before I do some more hands-on therapy. Well, then we're not helping that much. You're probably just like encouraging natural recovery times. And at that point, it's like, okay, like good, but you could be helping more. Like you could be helping more.
Nice.
I wouldn't want practitioners who do hands-on therapy to think, well, I can't touch people anymore. I can't do what I know I'm good at anymore. Because for a lot of people, they still want that. And if you take that away and you go, oh, you just have to walk and do it yourself. Well, fuck, that's not helpful. It's like, you know you could provide that person with some value if you put your hands on them, so do it. That's what I'd say to that.
Nice.
Your opinion?
Agree. Yeah, 100%. And I think if you don't address that and people just like, they keep their mouth shut and they just like, oh, this doesn't seem right, but I'll just go along with it. And then I keep doing these fucking questionnaires every few weeks. By the time I get to week 12, I'm still giving the same answers as I gave in week 1. And then this flowchart directs me to review with a musculoskeletal, a specialist. A specialist.
Yeah.
Then it's like, well, I don't know what that person is going to say. But if they've gone through the process of going through 12 weeks of therapy and nothing's changed, well, maybe the indication is to actually do something more interventionist in that example. So I agree, like by just ignoring patient preferences, it might not be the best solution for the individual. But you're absolutely right. If you are going to apply those modalities, then there should be a narrative around, well, you know, this might be short-term relief. There are other things you should do between sessions, and we are going to progress fairly quickly into more of an active approach, because that's what we understand is useful.
And you don't need to like then devalue the therapy that you're doing. Like, just because you're saying, hey, doing things actively outside of our sessions is going to help, isn't saying that what you're doing isn't helping. Like, you could still integrate those narratives super well. I think that's what good practitioners do, is they go as like, hey, you're going to feel a bit better after today, which is great. So what you then need to do is take advantage of that and use your body, move it a bit more, because that's going to help encourage recovery as well. So with the window we've created for you to move more, move more. Yeah, that's a very easy thing to say. What I think doesn't work as well in some musculoskeletal conditions, especially the more longer term ones that don't seem to just be regressing to the mean and recovering within the 8 to 12 weeks natural history kind of thing, which unfortunately, like, there are a bunch of Workcover clients that are like that, who have been going for 6 to 12 months with the same shit, is that you do your therapy, and whether this is like active therapy in the session or a hands-on passive therapy in the session, people spend the whole time completely engrossed in what's happening in that session. They're not necessarily talking about what that person should be doing in these hundreds of hours that they're not with you. Because that's, unless you're seeing someone 4 times a week, plus, you're not making these big activity behavioral changes. Because I will go see a chiro and I'll feel really, really good. And while I'm feeling really, really good, they're telling me to do some exercises. But as soon as I leave, I've forgotten them because I was too busy feeling really good while I was there. And I finish it and someone goes, how's the chiro? It's like, I feel great. It's cool. No one asked, so what's your homework? I was like, I have to do this for the next, I have to do this every morning. And I have to try and move my body like this. And I go for this walk and blah, blah, blah. And all these things. No, it's too busy feeling really good. So if you don't make a point to focus on making behavioral modifications and actual change to what this person's doing on an everyday basis, then I think you're missing out on a big part of what therapy should be, which I think that this document is simplified to encourage self-management strategies. And they've done it in a 1-sentence line, but that's really the main thing. It's the main thing. It's do whatever therapy you're doing to help them, but make sure they're doing the right shit. It's going to help them and not hinder them for all the other bloody hours of the week.
Yeah. How's your beer going?
Yeah, just about finished the first one. I've clearly been talking more than you have.
You have, yeah.
Can't help it.
Still not great, is it?
No,
it's not. It hasn't improved.
I don't think I'm going to open the second one. What I'll do is I'll leave it in the fridge because we still have some other beers in there for next time. Andrew, any other thoughts from this? There are some other principles, and we can go into the timely referrals and the begin with simple analgesic medicines and stuff. They're all kind of straightforward in terms of this is what you do if you're a GP. Give them some over-the-counter pain stuff to take the edge off, help them sleep. Try not to use the anticonvulsants and the antidepressants. It's we get that, but we can't do that anyway.
Yep.
So we don't really need to address that too much. I feel like this document is definitely a step in the correct direction. Definitely a step in the correct direction. Because they also link to some really useful educational resources like the ACI Pain Management Network and Pain Ed, which has a YouTube video which is appropriate for patients, and they have a website. There's a low back pain information for consumers. So there's some useful shit there. Very useful shit there that people should read. And they should read through this. And in general, you should agree with most of what's said. If you're saying no to all of it, you're probably going against what most of these smart people who put this together are suggesting you do. And then that might be a time for some self-reflection around who's right here? All of these Australia-wide bodies of experts, in inverted commas, who put this together, or me? And if it's you, well, good on ya.
Well done. Congratulations.
Other thoughts?
I agree. We chatted again just before this about that there was some rumblings in certain communities about these sort of documents being released. But like you said, I don't think it's not like professions are going to be cut off from treating these sort of clients. It's not like the new kid on the block is out there to get you. I think if there is obviously still a place for evidence-based therapy, and it just gives a bit of a time frame and a bit of clarity on when we should review these things, and if we're not seeing the improvements that we thought we would be seeing, great, now we know what the next steps should be. That's my biggest takeaway from this. It probably wouldn't change the way that I would schedule my treatment or anything like that. It probably just reassures me that I've got kind of somewhere around the 12-week mark to start to see some changes and see some improvement. And if I'm not, okay, well, maybe I should get a second opinion. Because that's in the patient's best interest, but it's also in line with what we would expect from a recovery time frame perspective. So, yep, agree, step in the right direction, but not a huge change, particularly in the people that are already on board with the active approach to therapy. There's not a lot particularly new with this one.
But it also tells you the correct, kind of the right things that you should be basing is improvement happening. It's yes, do an Arebro if you have a person come in with musculoskeletal pain. It's very useful. It will give you some good insight into their beliefs and what their hope for recovery is, and some areas where you can inquire further into what they think about something, and then you can retest as well. It's quite a good test. Nowhere on here does it say that they need to pass stage 7 of the abdominal test and have the best glute endurance in the world. Unfortunately.
Damn it. How annoying.
No more glute bridges, Andrew.
No more glute bridges.
No more Swiss ball.
What will I do?
No more Swiss ball hamstring curls.
Oh, they're the best exercise.
Here's a little bit of a throwback. So back when Andrew used to see clients, and I'll give him a fair shout here that this was probably 5-6+ years ago, and it was more the long-term clients that were still doing this. Is every single client that Andrew saw, no matter what they were coming in for, they had to warm up every session with 2 sets of 20 Swiss ball hamstring curls and Swiss ball dead bugs.
Yep.
Because how can you exercise?
I don't know how you could exercise without those things.
I don't think you can. I actually don't think you can.
It's the most important thing you can do. Because
if your hamstrings and your abdominals are not activated, then
it's all about activation.
What's the point of moving?
There was some sling work in there. You got to activate the something anterior oblique sling.
Wow, very good
with the thing and
with the contralateral
pressure
yes.
on the dead ball on the Swiss ball.
Very good.
And just hamstring curls because it was funny when people cramped.
Yeah, and it also bought you some time to set up the session and think about what you were
going to do. I was trying to work out remember what their name was and remember why they were coming in.
Why am I seeing clients?
Is it neck pain? Oh, Swiss ball. Just hamstring curls. Yeah, it's
meantime,
good for your back.
It's fuck, trying to...
I forgot to do my notes from last time. Hang on a minute.
Yeah. And I'm also trying to fucking open another clinic gym somewhere else, and God, this person's on the ground. Oh shit, they're talking to me.
Hang on a minute. Now, was it your left shoulder or was it your left hip?
How's the
body?
How's the joint in question going? An Andrew classic, and I still use this one, is what's news? Which is a great first question because it immediately makes people think about what's the most interesting thing that would make my 6 p.m. news story if Andrew was watching it. And you say, what's news? And they go, I did this interesting thing. And you go, great, here we go. This is what we're going to talk about for the next half an hour.
We're in.
Which is
Tell me more.
Yeah.
Tell me more.
It's a great first question if anyone needs one. It's what's news? What else did I learn from Andrew? Watching him do things.
That's all. There's nothing else.
No.
There's nothing else.
How to effectively swing a 7-iron while the client's doing their exercise.
It was a great time to practice the golf swing.
How to use pauses effectively, which that's not sarcastic at all as well. Like a good pause, which doesn't work on a podcast. So we're not going to do a good pause on a podcast. Is very effective at getting people to think a little further about their response to your last question, especially if you look at them with a thoughtful face of, Don't say the though. I don't like that.
No.
Don't like
No.
that. Hold on. But if you just look at them and go, no, I said it again. If you just look at them with a face. Or sometimes you go, so how's things? And they go, yeah, good. And then I go, are you?
Really?
Yeah, really? Yeah, you do a good really. It's a bit, I almost do that. I do that all the time, especially with clients and team members. You come and sit down and go, hey, so how's things? And they go, yeah, good. Yeah, really? Or, are you? Oh, good. There's a good one that I put there. Because then people either, they reiterate, no, like, I'm actually good. And you go, okay, cool, just checking. Or they go, well, no. And they're like, oh, what's going on? You can't really go wrong with that, like a second inquiry into the how are you or how's things.
I don't know where I got this from. I saw it on I don't know, Instagram, YouTube, something short recently. And I think it was maybe around men's mental health, right? And this little thing sort of goes like, you ask a bloke how he is. And if the response is, I'm all right, they are not all right.
Yeah, absolutely.
And what it takes is just that next question of like, really? For them to feel like it's a safe, like this person actually gives a shit and now I can talk.
What shows you've read into their emotion a little bit more and they go, oh, this person knows. If you go, oh, okay. Then
cool, we're going to do some Swiss ball.
Yeah, that doesn't open another question, right? It's the same thing with the, like, are you okay day? And I think it leads to a lot of, like, surface level shit of, oh, are you okay? Oh, yeah, you okay? Yeah, great. Like, great.
Tick.
So it has not actually done anything that we wanted to do. That it's still a fine question if you follow up with the, really? Or are you? Then it's okay. But if you just go are you okay? If you say, are you okay? The default response is yes. People have to really be overwhelmed generally by the no to say no. I feel like
I
80% yes, even if it's not.
It's like 80% yes, 1% no, and then there's this pause.
Of like,
oh, yep,
and then
yep.
the person who is uncomfortable actually asking the question in the first place then goes, oh, okay, cool, great.
Oh no,
Yeah,
I don't want to talk.
I don't
about
want to
that.
actually talk about how you're feeling. And then ideally, it should cue you to ask more. Ideally. But I think a lot of the time, people are still uncomfortable about asking further.
And that's why you should do a mental health first aid course, because you understand what are the questions you should ask after that. And then what to do with that information after you get it. So it's not oh, geez, now I have to fucking save this person's life. It's like you just know how to follow up.
Yeah.
Which mostly involves just shutting the fuck up and letting them talk.
Yeah. Have you ever asked someone, like you say, are you okay? And they go, yeah, good. And then have you ever asked them, it's like, would you tell me if you weren't? You've asked them that?
Yeah, I've asked them that.
What responses do you get from that?
If I don't know the person, it's like, oh, yeah, absolutely, yep. If I've known them for a while, that might be trigger for them to actually sort of go, oh, actually, like, there's nobody that I can talk to this about. And I feel weird talking to you about it. I'm like, oh, like, I don't feel weird. Tell me a bit about what's going on. And then once they say one word, the rest just kind of comes out. But
so you have asked that question, and it led to you either read into it and then they go, oh, like, yeah, and you can tell that they're not actually okay with telling you if they're not feeling good.
Yep. Sorry, third option would be like, yes, but I also see a psych and I'm talking to them about this, or I'm talking to my doctor about this. So like, yes, I feel comfortable talking to you about it, but I don't want to talk to you about it because I'm talking to somebody else about it. And I think like mental health first aid, like so long as there is an outlet for that and it's being dealt with in a professional way, like that's good.
For the people that give you the fake, yeah, totally. Where would you go from there? And maybe not in like a perfect mental health first aid way, but as a human.
Can you give an example?
Like, you say, Archie, you okay? And I go, yeah, I'm good. And you go, would you tell me if you weren't? And I go, oh yeah, totally. But you kind of read that.
Oh, you just don't seem like yourself today.
Yeah.
Yeah.
That's a little more direct. And you're showing that you're noticing something. And if they then back away even from that question, okay, all right.
Then they don't want to talk to you.
They don't want to talk, yeah.
Or they're either not ready to talk about it yet, or they just don't want to talk to you about it.
Yeah.
In which case, there can still be a reassurance. It's like, oh, look, if you ever want to chat, I'm here. Or if you need to if you feel like you need some professional guidance, I've got some great people that I can recommend. So you're at least allowing them to come back to you at a later time saying, oh, like when you said that thing, maybe I'm ready to talk about it now. Or maybe I do want to speak to somebody else about it.
Cool.
Very good.
Random tangent, but some other
Useful.
other useful random content for us today. All right. Well, we'll fade out into the and we'll see you next time.
Goodbye.
Bye.